didn't add is the dose. I couldn't find anywhere if it was a baby aspirin or a full dose aspirin, which I think makes a big difference. But it's a totally different pathway. Aspirin versus, aspirin's a platelet mediated. So it's not the same type of anticoagulation as the medicines, but they're saying if there's no risk factor, then throw it on. So we talked about the low risk PE treated home versus hospital discharge. I have seen people discharge people from the ER, and I'm sure that it happens and it works fine. The problem is that if you're the provider who has to go to a family member who's died, and I have to tell you, well, I know that he was in the ER with a PE 3 days ago, and I know that we said it was okay to send him home, and I'm sorry that he died. When you're on that end of it, you aren't really stoked about the idea of sending somebody home. They say that, the guidelines say, if somebody's clinically stable with good cardiopulmonary reserve, meaning they're a younger person, not somebody with an EF of 10% with horrible heart failure. If they're hemodynamically stable, they're not requiring any oxygen, there's no contraindication to a newer agent. These people are all going to have to be treated with newer agents. You would never send somebody on Coumadin that's going to take 3 days to work. The only way that you would ever send somebody home from the ER on anticoagulation would be the newer agents, Eliquis, Xarelto. So if there's no contraindication for that, they don't have any recent bleeding, their platelets look okay, they don't have liver disease, and if they're comfortable being treated at home. That's another huge one. Actually, a lady who works in her office, her father-in-law has a huge leg, and he's got clot burden all over the place. He's got bilateral PEs all the way down, and they wanted to send him home. And they weren't real comfortable. She wasn't real comfortable with that because we take care of people that get sent home if they get back to the hospital in time. So the family has to be very okay with the fact that you're sending them home with a blood clot. I'm just going to tell you that I would never do this. I would never send somebody out of the hospital from the emergency room with a blood thinner for a PE. If you wanted to bring them in the hospital, you don't have to keep them for 5 days. You could keep them for a day or two, slap them on their Eliquis. If after a day or two they're doing okay, that first 24 hours is your time for clot stabilization. So after the first 24 hours, your chances of other clot elsewhere breaking loose is very small. So if you can get them through 24, 48 hours of anticoagulation and they're okay, then send them home. So just a couple day even observation in the hospital, and we're sending them home. So the guidelines are leaning towards maybe we can, but they were very waveringly on that. As far as recurrence, if anybody has had a blood clot on therapy, a couple of things that you have to think of. Number one, is it really a new clot? Or is it old clot that didn't go away? We don't ever rescan somebody after we treat them to see if their clot goes away. So you have to decide, is this really another clot? The other thing you have to check is, are they compliant? You can check a factor 10A level, and if it's there, they're taking their medicine. We had a lady who swore to us that she was taking her Lovenox until we checked her 10A level and it was normal. And then she said, well, okay, I'm going to take it every day. So you have to decide, are they compliant with their medicines? And you also have to decide at that point, is there some malignancy we don't know about? We just did a CT abdomen and pelvis on a lady that we have no reason why she clotted. And so we have to kind of look for a cancer. Didn't find anything, but sometimes you'll find things that way, that somebody's clotted without any reason for it. The other recommendation is if you have a patient who has cancer and gets a clot on Lovenox, their recommendations are that you can bump the dose by a quarter or a third and check a 10A level and make sure that they're therapeutic. As far as prevention, this is kind of a big difference between academia and everyone else. So at OU, there's lots of studies. There's lots of studies out there that say that leg squeezers or SCDs, sequential compression devices, are just as effective at preventing blood clots in people in the hospital as chemical prophylaxis, which is Lovenox or heparin. And so they recommend that you could just use SCDs on everybody, and that's going to be fine. Well, I can tell you that I've seen tons of people who have blood clots on SCDs, and SCDs don't help at all for PICC lines. So if you have somebody with a central line, you've got to give them blood thinner. So when you give people, almost everybody in the hospital is going to be on a low-dose blood thinner. We usually use Lovenox because once a day. Some facilities will use heparin, but it's Q8 hours, so they get 3 shots in their belly a day instead of just 1. It's a sub-Q injection that's given in the fat pad of the stomach, and it's just once a day. It's 40 milligrams a day for normal people. It's 30 milligrams a day if their creatinine clearance is less than 30. So most of your dialysis patients will just get 1 shot once a day. If they're large, with a BMI greater than 40, they're going to get 30 milligrams twice a day. OU, we have started doing this weird I'm not sure what their calculation is, but we also work at a long-term acute care facility, and we see people, trauma patients coming from OU with these weird dosages that we can't really figure out. It's prophylactic, but I'm not really sure where they came up with their calculations. So you may see other things. Like I said, you go to an academic center, such as OU, I keep mentioning that because that's the one that you'll see. Academic centers put a lot of faith in studies, and so they are more likely to do things that not everyone else does. And when it comes to prophylaxis, again, I don't want to be the one having to go to a family member and say, you know what, or a person and say, you're going to have to be on blood thinner for the next 3 months because we thought STDs were good enough. People get blood clots on STDs in the hospital, so we're huge fans of Botox on everybody who walks in the door. They're sitting in a bed for 23 hours a day. Oftentimes they've got multiple risk factors, so I don't like STDs unless they can't have Botox. But the idea is that all of those things have been shown to reduce the incidence of PE in hospitalized patients. That was really fast. Was that like a lot of information in a short amount of time?
No, I like
Yeah. Any questions about all of that?
If you're already on aspirin, if you're just taking daily aspirin, and then say you end up with a clot and you're put on Botox, you need to stop your
We
daily.
usually do.
Just go ahead and stop it.
We'll stop all aspirin, and that was one of the things when they talk about resuming aspirin, is if somebody was on it before and you stopped it, then you add it back on after you stopped it there. There's a lot of people who are on baby aspirins for heart reasons, but we'll stop them. The other thing to keep in mind is that NSAIDs, ibuprofen, all of those are blood thinners too, so we recommend that all of our patients that are going home on full dose blood thinner take time off for their pain of choice.
My question actually also had to do with aspirin. Do you know why aspirin's not effective for pulmonary embolism when it is for other types of embolisms?
How aspirin works is it coats your platelets and it prevents platelet aggregation, which is just one arm in there's multiple arms of the coagulation response. And in fact, you've got factor Xa inhibitors, you've got vitamin K, there's all these different pathways for clotting in the body. And only platelets is a very small part of the clotting process. And so that only stops it here where there's all these other ways of clotting. So you can't use that alone. You have to go further up the pathway, if that makes sense. Going once. So do you want to take a break and then we'll go back and do the implacins?